Welcome to the forum at the Harvard School of Public Health. We're here today for a program titled Step by Step, The Path to Ending Child Mortality. My name is Charles Sennett. I'm the co-founder of GlobalPost, and I'm the moderator today. I want to introduce our panelists. We have a great panel who can help us go into this issue, and I'll frame some of the discussion a bit later. But I just wanted to start off by introducing everyone. To my left is Elizabeth Gibbons, who is Senior Fellow at the FXB Center for Health and Human Rights at Harvard University. Elizabeth was formerly the former Deputy Director for Policy and Practice and Associate Director of Gender Rights and Civic Engagement at UNICEF. Thanks for being with us. And then further down is Regina Rabinovich. Regina is the ExxonMobil Malaria Scholar in Residence here at Harvard University. Thanks for being with us. And we have Jacqueline Baba, who is Director of Research at the FXB Center for Health and Human Rights at Harvard University. And we have Richard Cash, who is Senior Lecturer on Global Health and Pioneer in Oral Rehydration Therapy, also Harvard School of Public Health. Thanks for being with us. So I wanted to start today just by sharing the framework here for a 1-hour discussion where we'll have 2 question and answer periods, and we're going to show you 2 short videos. We hope that we can get into a discussion of what works and what doesn't work in terms of a really dramatic period in which we've seen child mortality decreased. There's been pretty stunning developments that we've explored through our reporting around the world in how people are working hard to really bring down this rate of child mortality. And we want to get into the specifics on what is working and what is not and hear from our panelists on that subject. This is an extraordinary collaboration for us at GlobalPost to be part of the Harvard School of Public Health on its 100th anniversary. It's a real pleasure to be here. We think that there are so many experts we draw on here for so much of the reporting we do on global health. And we want to describe the project we did, which was funded by the Kaiser Family Foundation, which is called Step by Step. We did this in partnership with Kaiser and brought in a lot of reporting fellows and research fellows from Columbia University, and some of them are here in the audience. I'll try to introduce them later as we go along, and I hope they'll be among those who will ask questions. We felt like this topic of child mortality was one where we could really come together and try to look at that issue, which is really the most profound way in which we should judge societies. Our success and our failure should be judged in the end of the day on how we take care of children or how we fail to take care of children. No more vulnerable population in our world than children, and to know that there are 6+ billion children who are dying every year before the age of 5, largely due to preventable diseases, is really a crisis. Even though there has been, as we've said, dramatic success in lowering that number, to think there are still 6 billion and more who are dying every year is extraordinary and something really to think about. So what we want to do is show you a videotape which was produced by GlobalPost's Emily Judum, and which incorporates a lot of the reporting fellows here and tries to frame the issue.
In 1990, more than 12 million children died under the age of 5. What we've seen since then is a huge amount of progress.
Out of the 1.7 million under 5-year deaths in India, nearly 900,000 are in the first month of the child's life.
I decided to look at pneumonia because it is actually the leading cause of death for children under 5 years old. There are an estimated 120 million children who had suspected pneumonia in 2011 alone, and it has a really high fatality rate.
There's still around 700 million people a year that are affected by the unclean water issues. And to me, it feels like a battle zone. It feels like an undeclared war.
Malaria is truly the perfectly honed killer. And in this part of Zambia, it's not uncommon for children, men and women, to have malaria 8, 9, 10 times in their lives. And yet it's preventable.
Today, about 7 million kids die under the age of 5. And that's extraordinary progress. Solving that problem, ending preventable child death, helps make our world more stable and more prosperous.
That video, I hope, helps us frame some of the issues. We heard Rajiv Shah from USAID there at the end talking about how ending this problem really is important for all of us. It's a way that we are going to have to see the success of our society will be in continuing to work to lower this number. But Liz, I hope you could start us off just by talking about your work at UNICEF, and think broadly for us for a minute. Help us define some of the key issues we need to focus on, and maybe highlight the most recent UNICEF report and what key problems were highlighted there.
Well, thanks first of all for organizing this panel. I mean, it's the big issue, really. I mean, the right to survival for millions of children, and it's a silent emergency, so thank you for bringing attention to it. Yeah, the latest report actually shows continuing good progress. I mean, from 12.6 million children per year dying of preventable causes in 1990, it's now 6.6 million. So that's 47% decrease. It's a huge decrease. And the speed of decline is also increasing from around 1% per annum in the 1990s to close to 4% since 2005. So that's really, really good news. But the progress is very uneven. They're uneven between regions and uneven within countries. So where the Millennium Development Goal for 2015 was 2/3 reduction in preventable child mortality globally, it's nowhere near going to be hit, with only 2 regions that are close to that, which is, in fact, Latin America and East Asia. The big pool of child mortalities remains in Africa and in South Asia, which is 80% together. And the causes, as I know we have some esteemed people who will discuss more in detail, the causes are largely preventable, but neonatal deaths, neonatal is the cause of 44% of deaths, and that's one of the most difficult periods to deal with. Pneumonia, 17%. Malaria, I think around 7%, if I'm not mistaken, and diarrhea around 10% as a cause, immediate cause of death. Obviously, these are completely preventable with the right kind of services and with the right kind of support. But beyond that, within countries, there's a huge issue of who's being left behind by the progress. And it's the poor children who are being left behind. Poor children are 2 times as likely to die as the richest children. If you're in a rural family, you're also twice as likely to die before your 5th birthday. And if your mother has no education, 3 times more likely to die. So there's enormous inequalities within countries, and even the stars of MDG progress are not addressing it. Bangladesh, which has had an incredible progress reducing child mortality 67%, still the poorest Bangladeshi children are twice as likely to die as the richest. So they're not benefiting from the progress. And a country like Ghana, where actually the reduction in mortality of the poorest is 34% compared to only 19% in the richest, they should be getting enormous international recognition. But they are deemed off track for the international MDG because they haven't succeeded in reaching 2/3. So I would leave you with the issue of who's benefiting from the progress and what needs to be done to be sure there's more equitable progress.
Okay, thank you. That is a great overview. I want to try to go into some of the areas of expertise here as well on the panel. And I would ask the panelists to please try to keep it to about 2 minutes so we can stay on track, which we are on track, thanks to Liz.
It's off.
Regina, if you could maybe spell out for us sort of the toll of malaria, of pneumonia, rotavirus, and what part of this do we need to be concerned about? How do we look at HIV and AIDS in this broader context?
I think it can get a little bit overwhelming when you look at all the numbers, because child mortality is the net result of failure to deliver some technologies, of the required health systems that are required to be able to reach the hardest and most at-risk population, and complexity of different diseases. So let me just simplify it to 1, 2, 3. People usually think when I'm, malaria scholar in residence that number one would be malaria, and it's not. It's pneumonia. And we've been pretty persistent in that. A child that gets a respiratory infection in an endemic area was 10 times more likely to develop pneumonia than a child in the United States. So the risk factors, because of a variety of conditions, including malnutrition, is much higher. And once they have pneumonia, they're much less likely to get treated because of lack of access to a simple antibiotic. So what works? Prevention works. And I think that's going to be my theme. Whether you're talking about pneumonia, diarrhea, or malaria, prevention works. And for pneumonia, it's 2 vaccines, Hib and pneumococcal vaccine. Also, some aspects of measles that are really having an impact in helping drive those numbers down. What works in diarrhea? Well, we're still in the process of scaling up a rotavirus vaccine. Oral rehydration for treatment works, prevention works. And what works in malaria? We've done lots of advances in access to good drugs, but what works? Bed nets work, prevention works. And so it's the promise of adding new tools, but the commitment of country leaders under the MDGs, which you brought up, but I want to emphasize it's not just a paper exercise. It is about countries holding themselves accountable to the health of their children. That works.
Okay, thank you. And Jackie, Baba, I wanted to ask you to really bring us into some of the issues of equity and gender as they play out in this drama, or as Liz called it, this silent emergency. How do we look at the young, particularly poorly educated girls who are married off too early, and to what extent is that huge swath of population that's just marrying too young, how does that make the women and then therefore the children they produce particularly vulnerable? And help us focus specifically on infant mortality, and to look at this dramatic toll on children 1 month or younger.
Sure. Well, I think that some of the main themes have already been brought out, and I'd just like to emphasize them within maybe a more human rights context. So I think the 2 big problems we're dealing with here are the failure to respect 2 cardinal human rights principles. One is the principle of equality, and the second is the principle of non-discrimination. And in a way, both of these work together to create this silent emergency. So what do I mean? Firstly, the question of equality. So we've heard that for rural populations, for populations who are poor, for populations where education is lacking, particularly for the mother, they're much higher risk. So why does this continue? Why is there this inequality? And I think here is where we have to start really paying attention. So these are clearly political decisions, a question of political will. So of course we do need new technologies, and we do need the diffusion of new technologies, but we also need a more basic social and political commitment to equality, to distributing goods more widely and in a less partial way. Secondly, the question of discrimination. There are many levels at which discrimination affects the problem that we're talking about of child mortality, but I would just mention 2. Firstly, gender. Gender discrimination is a huge factor. The fact that the girl child, first of all, is less likely to survive, and secondly, if she does survive, is less likely to be adequately nourished, adequately educated, adequately protected from violence, or adequately able to get a job and to earn. That has an enormous impact on our problem, because these young women are the mothers whose children are most likely to die. So there's a close connection between the gender discrimination and child mortality. So in terms of prevention, which is I think what Gina was referring to a minute ago, we need to prevent the diseases from taking hold. But even before that, we need to prevent women who are mothers from being handicapped or disadvantaged in the way they are. So I think that's one of the most sort of critical issues that we confront. So child mortality would be far, far less if mothers were educated, if mothers were empowered, and if mothers were older.
Okay, thank you. Richard, your expertise on water and waterborne diseases, and specifically looking at dirty water, I wanted to ask you about remarkable improvements that have been made in that area, but the idea that there still remains a human toll that is devastating, that's linked to these waterborne diseases, diarrheal diseases, and also nutritional deficiencies, and maybe try to explore the line between mortality and morbidity.
Thank you. And again, thanks to the organizers for putting this panel together. First of all, I'm very much a glass half full type person. Actually, the reduction has been almost 2/3 because the population of the world has increased 30% since the original predictions were out. It's around 39%. It's around 61% reduction. So we're doing better than we even give ourselves credit for. My concern is that we have focused very heavily on mortality when in fact morbidity is an equally important issue. If children are sick a lot, if they are not able to fulfill their capacity, we've got a problem. And by simply focusing on mortality, which so much of the focus has been on, we ignore issues such as contaminated waters, such as poor educational systems, as Jackie was referring to. And so it's all of those, that other package of development issues which are critical. What we don't want is successes in mortality and people still living in abject poverty. And in fact, that is what has happened. Our tools are very powerful, our vaccines are really good, our interventions are very good, but we haven't adequately addressed the underlying risks and causes of both the mortality and the morbidity.
Okay, thank you. And so that, I hope, frames the discussion from the different points of view of our experts on the panel. But now we want to go to you. We want to hear some of your questions in the audience, and we also have an audience online that will be asking questions. And our first question will go to Penny Duckham, who is with us here from the Kaiser Family Foundation. As I've mentioned, Kaiser is our partner in this project and has been for several years in supporting global health reporting at GlobalPost. It's work we care about, and we couldn't do it without Kaiser. And thanks for that, Penny. And Penny, I wanted to just throw the first question to you.
Thanks, Charlie. As reporters coming to this field, I think one of the most striking things is the number of goals in global health, and child mortality issues are no exception. This morning, you've only mentioned the Millennium Development Goals, but how useful are these, and do they overlap? Are there too many of them? Do they really lead to accomplishments or perhaps to disappointment because they're almost never met?
Who'd like to take that up first? It's a hard one, but it's one that we saw our reporters really struggle with. How do we gauge the metrics?
I think the 2015 goals, which have been already pushed back once, have been an enormous driver for action. And right now, as we're closing in on 2015, countries are realizing that some of them will make it, others will not. It is surprising to me how much it is creating a focus for what is important to do right now. What can be achieved by 2015? How to advance that agenda even more quickly. And it's happening at a financing level, the refinancing of the Global Fund, which is all about making the resources available right now. So I think that in that way, it can be very helpful in terms of creating that focus and some accountability around it. I also know there's lots of brochures and plans and reports that are sitting on bookshelves which embody others. So I think it's not the goal per se, but the process of generating them and country ownership. And if the country doesn't own that goal as something that they aspire to, you know, you could save the paper.
It's not going to happen. Well, why don't we, Jackie, do you want to sort of respond quickly, and then we'll have Liz as well.
Yes, well, I think it's a very good question, and it's a fair question because inevitably the MDGs have attracted both supporters and critics. Supporters for the reasons that Gina just outlined, that there really has been a focus of attention and a sort of tangible set of benchmarks which can guide policy making, and that's always useful in a complicated arena and a contested arena. Criticism because, of course, inevitably stuff is left out. So people who work on gender-based violence have been critical of the MDGs. I think there are the focus, for example, in education on primary education has left out other aspects of education, which, as I hope we'll discuss later, are critical to empowering girls and young women. And also the interconnections between the rights or the goals are in a way obscured by having these discrete 8 bullets. So I think there are 8. So I think there's something there which is which you know, hopefully can be improved upon as we move beyond 2015. And I would just say that from the human rights perspective, there are other goals embedded in our international human rights conventions which many countries have signed on to, and the fact that MDGs are now the primary focus for many shouldn't obscure the fact that these other fundamental human rights goals are also binding on states, and I hope that they can come back into the forefront of attention.
Okay, Liz?
Well, most of what I would like to say has been eloquently stated by
Anything
the
you
other
build on
panelists. Well, I really want to emphasize the human rights aspect and the issue of equality, which was very much left out of the MDGs, and national adaptation, because as we've seen in some of these examples, global goals aren't always appropriate, and they actually then marginalize popular participation in assuming and actually working towards the achievement of such goals.
Okay, we're going to take a question now from the online audience, and that question is?
We do have a lot of questions coming in from India, so I'm going just to take one of those as an example. This is from Priyanka Borpujari from Mumbai, and she says, "Hello. I am an independent journalist in Mumbai, India. Last year, I was auditing a course on infectious diseases conducted by Dr. Richard Cash at HSPH. Back in India now, I am reporting on health issues. Here is my question to any one of the speakers. Have there been any instances where listening to the local needs and cultural mores have led to localized ways of tackling the causes of IMR and thus reducing child deaths? This I ask given that the causes are global, yet ways to tackle them often need very localized mechanisms. I would like to know of such cases. Thank you."
Richard, I think that would be best for you to start with that one, since she is your student.
And a very good student, I might add.
Great question.
No, I think that obviously the other panelists have alluded to this. When you set up international goals, there is a tendency to look for international solutions, and I think that's a terrible mistake, because a lot of these things have got to be adapted to local realities and local issues. The problems of someone living in a water poor area are very, very different than someone living in Bangladesh, where there's water everywhere, and so on. And the goals may be very different. So that I think that I'm trying to think of a specific example of where this might be the case, but suffice it to say that you have to develop local solutions for local problems, and that's one of the problems I have with MDGs. It's driven by an international agenda, certainly often not by a country agenda, and certainly not by a local agenda. An example of this might well be something that probably people would rather I not talk about, is polio eradication, the attempts to eradicate polio, which is very much of an international agenda, but may well not be the agenda of local governments and others who say, well, we've got a lot of other problems here. Why are you having us do national immunization days 5 times a year? What about the kids who are dying of meningitis or pneumonia or diarrheal disease? That's but one example, and which will get me to cross swords with certain people who don't necessarily share that view. But that's one example.
Okay, that is a perfect transition, I think, to the next part of our discussion today, which is to try to look more deeply at what works and what doesn't. So we want to challenge you more about what is working and why, but also really take the time here to look at what's not working and where there needs to be improvement, where there needs to be good journalism that can highlight the areas that aren't working, and what productive questions should we be putting out there in the field through these amazing young reporting fellows we have from GlobalPost who are here. One of them, Harman Bopare, is from India and did a very powerful field report for us from there. I want to go now to one more video clip which will really look at this issue of dirty water and allow us to transition to that issue and start to explore how that really lies at the core of so many of these diseases.
$1,800 kids die every day from unclean water. As tragic as the wars that are going on worldwide, it's very rare that you hear about 1,800 people dying every day in any war zone. Kube in Freetown, Sierra Leone is an example of these battle zones that are around the world. It's sewage everywhere. Children are bathing in what is known as the Crocodile River that runs through the neighborhood. And I was told there was 7 places to find clean water within the neighborhood. And so this is a photo of a young man who ran out of clean water and who was going to go around here and finish his shower. You just look at this stairwell of water and garbage, and you wonder, where is it going? Kids would walk outside their front door with a small metal can and a bar of soap, and they would just literally walk right into this horrible dark water. These kids lived about 500 feet down the river. A half an hour later, a little boy bathed right here. In this case, even the teddy bear is injured. There has been great successes since the early 1990s with maternal infant mortality and access to clean water. Absolutely. But when 600 women are dying a day and 1,800 kids are dying a day, how is this not a crisis?
That film features the photography of Dominic Chavez. Dominic is a Boston-based photographer. Many of you may know his work, but for many years he's looked at this issue of child mortality and particularly at dirty water. And he was my colleague at the Boston Globe. We were really proud to have him as part of our special report on GlobalPost. Just to ground you a little bit, GlobalPost is an online international news organization, and we're trying to take on these kinds of issues to get at sort of some of the core problems, the toughest challenges we face globally. And I think dirty water is one of those challenges that cuts across so many disciplines in reporting, but also in health, in human rights, and in great challenges to governments as to what they're doing to address this problem. So Richard, I think with your background and your expertise in this area, maybe you can start us off in looking at one question that really jumped out at us in our field reporting was the counterintuitive notion that India, a country so successful economically, really part of a booming economy, one of the fastest growing economies in the world, has done very poorly at addressing dirty water, and done certainly poorly in terms of the number of child deaths that are occurring there every year. How is it that a country like Bangladesh, which struggles so much more dramatically in economic terms and is really seen as an economic basket case, has had much greater success? What are the differences there between India and Bangladesh, and how can we learn from them?
Well, I think in terms of water, both of them are on par. Bangladesh has a lot more, and so that they, but they also have one of the largest mass poisonings, if you were, because of high arsenic levels in water. So we're talking about usually these kind of pictures which show, a lot of stuff floating around the water, but there's a lot of things in water that we don't see, and arsenic is one, and toxic chemicals that come out of some of the factories and so on. I'm not sure Bangladesh has done any better. They have done better in terms of infant mortality rates in some of their areas. I think all of these countries across the globe have had huge problems, not the least of which is because of the high rates of urbanization that are taking place. And so the infrastructure of cities like Mumbai and Dhaka, which when I lived there was 2 million people and is now 15 million people, and that's in a 40-year period, 45-year period. So you can imagine if Boston had it expanded at that rate, would we be able to keep up with the water infrastructure, the sewage infrastructure, and so on? So there are just simply overwhelming problems that they face. That said, they still haven't managed to deal with these. And I'm unfortunately, this is across the board. Okay. You could deal with, as I said, Mumbai and Dhaka and Ibadan and Nairobi, and all of these countries are facing a similar issue, not just with water, but also with sanitation. India has the highest rate of open defecation, another major problem that many of these cities and countries face.
Okay. I'm going to come back to you on what's not working, and I want to plant the seed on that now, and to maybe stay with Bangladesh and India as examples that we could go a little bit further into. But to shift the conversation to Liz Gibbons and back to human rights, and to try to focus on the MDGs and some of the post-2015 agenda around those MDGs, and specifically to look at this issue of coordination of funding within and across health sectors, and how to include all of the different constituencies in that funding, and continue to focus our attention and this discussion on the human rights aspects.
Okay, well, first of all, what doesn't work is expecting the health sector alone to reduce child mortality. It's impossible, and Richard has already referred to that. So we know that twice as likely to die if you're poor, 3 times as likely if your mother is uneducated. So poverty alleviation, girls' education is obviously critical, but those are very long generational processes. So what I would like to see very immediately is an intense focus on maternal mortality. I mean, this is about gender inequality, it's about child marriage, unwanted pregnancies, and the access to reproductive rights and services. So if you can end child marriage, you will immediately prevent a 4-fold increase in the probability of maternal death if the child is under 16, if the mother is under 16, and a 50% increase in the probability of her child dying if she's under 15. So there's immediately an action. FXB in East Africa is doing a very interesting study on the impact of maternal deaths on living children, and is finding that if a child's mother dies, this child has a 50% chance of surviving to the age of 1 versus a 95% chance if the mother survives. So right there, action on gender equality, on empowering young women will make a big difference. And there's also evidence that shows that countries which have laws that empower women have lower child mortality rates. The second, I think, really important focus, which again is a completely different constituency, is on universal social protection. Poor children get poor services, or services aren't able to reach their communities, but partly that the services that are there they can't afford. And one way to give them an equal chance at survival is cash grants to the mothers. And there's increasing evidence of the impact of social transfers and cash grants to families on child mortality. The very famous program, which many of you probably know about, is in Mexico, the Oportunidades program, 17% decrease in child mortality in rural areas when the family got the cash grant. 11% decrease in maternal mortality, 25% decrease in newborn diseases and illnesses. And there are other cases in Vietnam, in Thailand, 6% decrease in mortality when the government introduced an insurance scheme. So social protection is a really great way to focus attention on the poorest, give them an equal chance at survival. And finally, social accountability and public participation. That's key to the human rights approach, but it's also very effective in equalizing access to services. An example is Uganda, where there was frequent stock outs of essential vaccines and medicines before the introduction of the stopgap campaign, Stop Stock campaign, and where citizens would text immediately to the authorities when the stocks ran out. And the impact was, of course, much shorter duration of stockouts, less corruption, and of course, more availability of essential drugs. Second one is a really interesting case from Guatemala, where it really highlights the essential importance of disaggregated data, where a study was done on the right to maternal health, and it showed that indigenous women were 3 times more likely to die during childbirth, and indigenous areas received 1/3 of the per capita investment of an already meager health budget. And this was taken up by civil society, put pressure on Congress. Congress passed a law that insisted that there was a right to maternal health, and that right would be implemented without discrimination, and that there would be no inequality in the investment per capita, and then created a commission to oversee the implementation of the law. So you have there accountability in action. So those are the 3 things I would really say work, and we should be doing more of.
Okay, and then a very quick response to the idea of when you have multiple agencies working on the same issues on child mortality, how do you get them to work together? If you could answer that quickly, and then maybe some of the other panelists can come to it as well.
I think actually the example there is having a global goal like MDG4. It ended up forcing people to work together. The creation of the Partnership for Maternal and Newborn Child Health was created, and altogether more of an emphasis. But how you get the human rights community also engaged, I think it will depend on instances such as the one I just described, where you have a health problem that is then reinforced by human rights mechanisms.
Okay, Regina, your focus on prevention is something that we want to hear from you about. Some of the specifics on solutions to controlling malaria, TB, and pneumonia, particularly when we're in resource-poor settings. What are the issues to be thinking about there? What works and what doesn't?
I'd actually like to pull an example that doesn't fall in those 3, because it shows, it addresses the question of the input of the local community, prioritization, and then impact.
Okay.
And that is the case of meningitis in sub-Saharan Africa. It's something that happens in sub-Saharan Africa, not in other parts of the world. Every couple of years, big epidemics of predominantly meningococcal A meningitis. And they come in epidemics, 1,000 people ages 1 through 29 in the hospital. So it's very evident. It disrupts local priorities when it happens. It's something that politically has to be dealt with, and it can't be just an unseen epidemic. And there was an initiative to create a vaccine for that. And the people who received the funding to do that went back to the country and said, ask them a couple of questions. How much does it need to cost? And they said, it better cost less than 50 cents or we can't sustain it. And then they were asked, do you want a meninge A vaccine, or do you want better insurance, but it'll take longer? A meninge A C vaccine, a little more complicated, a little more expensive. They said, no, we have a problem now. We want meninge A. So they went off for years. They've developed it. And I went to the launch of this, and it was very, very telling. This was a vaccine for a disease they saw as a priority because it's an epidemic. And at the launch in Burkina Faso, they were supposed to immunize the population ages 1 through 29 in Burkina Faso in 10 days. And I went, and my boss went, "It'll never happen." And I came back, I said, "You were right, it didn't take 10 days, it took 8. 99.9% of the population, probably like 101%, I think some people may have gotten snuck in who were 30, wanted that vaccine. The challenge is, how do we turn some of these unseen epidemics like dirty water, like mortality in the first year of life, which are big drivers of the mortality and morbidity gaps that we still face, into visible epidemics that will drive change? Because with engagement of the community and with a voice about what's needed to intervene, I think we can be successful.
Okay, so you've pointed out a very successful program for prevention. But where are you seeing most dramatically a failure of prevention?
I see that where it requires systems that are very weak. Treatment of pneumonia, treatment of malaria. They're not expensive. They're really not expensive.
Where are we seeing that?
We're seeing that anywhere there is malaria and pneumonia in endemic areas. It requires a clinic or a place for a child to go to get an antibiotic. It's not part of a campaign. It's not part of massive distribution of bed nets. It's the child who still gets pneumonia or malaria or severe dehydrating diarrhea in spite of what we can give. And those children will still exist. That requires prompt therapy, and it requires it for those most fragile children who are furthest from the clinic and furthest from access, and usually born to mothers that have less understanding of how severe such a problem can be.
Okay.
And we are not good at doing that yet. We're getting better. There's some interesting things that are going on with empowerment of local healthcare workers and both volunteers as well as paid for by governments. But there's still a long ways to go. We don't have the systems in place well matured.
Okay, thank you. And Jackie, if you would help us look at this notion of community-based workers, how to train them, how to make sure that they're part of capacity building. And I'm wondering if you can put out some specific examples of, again, where are you seeing that working and where is it not working and why?
So I think that there are two comments I'd like to make. One is in direct response to what you just asked me, and the other one is a little bit broader.
Okay.
I think the notion that you maximize access to medical attention by training people who don't go through the whole long medical training is fantastically important and has had some successes. I think in one of your posts, actually, you describe a program in Zambia where there are community-based workers who have been administering drugs very successfully. And it's a wonderful example of how you can use somebody who, actually I think they were volunteers, which is a mixed blessing. People should be paid to do this work. But people who didn't have years of medical training, but nevertheless could diagnose these illnesses with fairly simple toolkit and then could apply, again, fairly simply remedies. So that's cheap, that's effective, that is, has the capacity to have an amazing knock-on effect. I know that there are programs in India, colleagues initiated wonderful community health training programs in Goa, not only for physical illnesses, but also for mental illnesses, issues to do with maternal depression or depression in response to HIV/AIDS, where you can train community-based workers to address the symptoms and to intervene in a much more cost-effective way. So I think there really are, and in reply to Priyanka's question, those are some local examples which really come from the communities, which come from particular contexts, particular understandings of what constitutes illness and particular ways of tackling it. Because of course, the way you understand illness is also community related. We here may have global notions about the indicators, but within particular communities there aren't. The last thing I'd like to say is that many of the critical factors that we've mentioned aren't simply addressable through a vaccine. Liz mentioned child marriage. Now, child marriage has been illegal in India for a long time. and yet it is pervasive. And we know that a very high proportion of rural girls, particularly low-caste girls, but not only, are married when they're 14, 15, 16. We also know that child marriage correlates very strongly with maternal mortality and with infant mortality. But there is no vaccine against child marriage. Just passing a law doesn't change it. And so what I would say is that we certainly need to be gung-ho and optimistic about some of the scientific changes we've made, and they need to be developed and spread more generally. But we also need to be aware of the complexity of changing social norms. So to really make inroads into the pervasiveness of child marriage, you need to change the way poor parents think about how they protect their daughters. That's very hard to do. You need to create different incentives. You need parents to think, well, the best insurance policy for my daughter is not to marry her at 14 so that I'm sure she has a husband and a family. The best insurance policy is that she goes to school, and that she goes to secondary school, and that she goes to university, and that she gets a job. So that's a huge transition. And we really don't have any vaccine for delivering that. So I would just say that I think we have to operate at multiple levels here, because if we could really tackle child marriage as effectively as we're tackling some of the illnesses, we would be really streets ahead of where we are.
And tackling that would come down to involvement in legal systems and trying to actually put forward a legal structure in which that would be, I guess, prosecuted.
Well,
how do we begin that process?
I think we already have laws which criminalize child marriage. That's really not the problem. And yet policymakers and elected representatives, it's well known in India, frequently attend child marriages because their electorate are having them. So it's a question of changing social norms, which is much less easy. Prosecution may be a way, but you know, if you prosecute an unpopular law, you're not going to stay in office very long. So politicians, there's no, as far as I know, there are hardly any prosecutions for child marriage, none. And you know, how effective is that? If you're the only one whose child doesn't get married early, whereas everybody else is, then you know she might be left on the shelf. So you need to change the way the whole community think about that. So I think we need to look at precedents, like the wonderful precedent from Senegal, where whole communities changed their attitude to female circumcision as a group norm. So everybody in a community says, I'm not going to circumcise my daughter. And then the whole community can kind of have the confidence that their daughter's not going to be left out because she's the only one who's not circumcised. So that's sort of, but it's hard, and I think criminal law alone is really not the answer.
So the layering and the complexity of all of these problems are enormous, and they are really why at GlobalPost we tried to go at this issue. But I'm sure all of you have more questions. So we're going to go into our final round here of questions and answers. So I want to throw out to the audience here first if anyone has a question, and I'm hoping we can particularly draw on Richard's expertise on waterborne, because I still haven't heard from him on what works and what doesn't. So try to direct it that way, and I'm going to try to see if we can get to Richard on that. But who has a question they would like to put forward here?
Thank you. Hi, my name is Emma Sheldon, and I'm a first-year student in the 2 years master program in global health and population. And across the board, we've heard you all talk about the interdisciplinary nature of this problem, whether it's with legal system, public health, and human rights, or public health and public infrastructure. And so my question is, as public health experts, how are you, specifically Richard Cash, how are you collaborating with experts in other fields to end child mortality, and how is the movement as a whole working towards this type of engagement?
I think that I work with a number of NGOs, one particular in Bangladesh called BRAC, which I think is the world's largest NGO. Let me just, and I think this is an important issue because people have spoken about how well Bangladesh has done in many areas. Part of that is because of the strength of civil society. That is, and the partnership between government and civil society. Government ultimately is the major purveyor, but civil society provides new ideas, different ideas, and this partnership, that is not to say everybody, you know, walks lockstep to the same drummer or dances to the same tune, That's one of the values of having different groups there. But this partnership in many areas is extremely important. I wanted to also address very quickly the issues that Jackie raised. When I first went to Bangladesh, and I sort of keep going back there, but that's my base, so to speak. There was clear gender differential in terms of mortality, much higher in girls than in boys. That's not true anymore. Life expectancy is greater for girls than boys. What has happened? Well, one thing that has happened is the garment industry, which employs millions of young girls. Their economic value is much more appreciated. Schooling, the number of boys and girls in school is equal. So those things have been reversed over a 40-year period. It can be done. It can be done, but it requires a multiplicity of factors taking place. It's not a health issue. It's not a development issue. It's society's issue. It's about the society itself and where that society wants to go and wishes to go. And as I say, I think there have been reverses, but I see these things certainly getting better and better if we keep our eye on the prize, so to speak.
Okay. Thank you. Anyone else who wanted to quickly address that? Because we have other questions. Yeah, sure. Another question, please.
My name is Aisha Sania, and I'm a postdoctoral fellow in Global Health Department, and I'm also from Bangladesh. So I actually have two questions regarding the new vaccines, rotavirus, meningitis vaccines. Are there developing countries that already have included these vaccines in routine immunization programs? And in terms of global commitment from the donors and development agencies, how far we are with pushing that agenda?
So yes, there are countries that have included that. The meningitis vaccine was licensed in 2010, and more than 150 million people have received it already. Wow. That's a massive scale up compared to what our expectations would have been a decade ago. And that's partially through funding from the Global Alliance for Vaccines and Immunization. For rotavirus vaccine, that has been slower because diarrhea sort of is either not talked about, less visible to people. Gavi has also included it, and it's expected that is being introduced now, and it's a country level decision because it's totally driven by public sector delivery systems and public sector financing. So yes, those have been. I think there's a malaria vaccine that was presented in Cape Town, in Durban yesterday, that actually showed about a 50% decrease in rates of malaria in toddlers, and that if you vaccinate 1,000 toddlers, they'll have about 900 plus fewer cases of malaria because they get more than one. So there's new technologies coming, but I'd like to, because I'm not arguing for vaccines, I'm arguing for effective prevention. And if the idea is prevention, let's figure out what the intervention is to actually make it uncool to have your daughter married at less than 16. If you can figure out that intervention and scale it, that's where you can have action that goes across geographic boundaries. So in many ways, prevention is an idea that needs to be made real by interacting with the community. We had some good examples of that.
So we'll take one more question from the audience, and then maybe we'll go to an online.
We've had a number of questions about violence, and so I just want to share one of them. At one point recently, I saw a statistic that said 9 of the 12 countries where child mortality is highest have suffered armed conflicts recently. What do you see as the relationship between conflicts like these and death of under 5s in terms of delivery of aid, vaccines, and such?
Liz, would you want to start us off?
Sure, I can start off on that. Well, one of the first things in countries of conflict is that the infrastructure is destroyed. So really just even access to health services is missing, so there's much more mortality due to that. But there's also a breakdown in social norms very, very often. So, routine practice of rape and abuse, which of course has an impact on maternal mortality, it has an impact on child mortality. So those are among the many issues that would correlate between violence and post-conflict and child mortality. But I was very encouraged to read in this last report that came out last week that one of the countries amongst the poorest that's actually achieved the MDG of dropping by 2/3 is Liberia. I was very, very surprised. So again, things can be done. It's just how we learn from that.
Okay. And did you want to add to that, Jackie? Did you want to give us the closing thought on that?
That's a great question, because of course, to some extent, violence begets violence. And so we know that as Liz said, in post-conflict countries, we know that domestic violence, gender-based violence often increases, and so what used to be exceptional becomes the norm, and we've seen that in the DRC with terrible consequences. And as we were saying earlier, young mothers are the most likely to give birth to babies that die. So where you have a crumbling or destroyed infrastructure, you have very high rates of gender-based violence, you have low rates of education, and you have a very gender unequal situation, then it's really, unfortunately, a perfect storm for increasing child mortality. So that is a huge consequence of violence.
I want to wrap up by thanking our panelists. It was really extraordinary. Thank you very much for joining us today.
Thank you
for having us.
I want to thank the Harvard School of Public Health for hosting this forum and for allowing GlobalPost to participate. I want to thank Kaiser Family Foundation as well for supporting our work on global health. And I want to thank you all for joining us both online and in the audience. Thank you very much.
Thank you.
Thank you.